Hello everyone, in this video we will cover antithrombotic therapy in patients with valve disease, antiphospholipid syndrome, and coronary artery disease. We will cover evidence-based recommendations for using warfarin, aspirin, DOACs, and dual antiplatelet therapy in these key scenarios. Now let's start with mechanical heart valves. For patients with mechanical heart valves, warfarin is going to be the essential treatment. DOACs like apixaban or rivaroxaban are not approved in this setting. The INR target is going to vary. It is 2.5 for aortic valves unless there are added risks like atrial fibrillation or venous thromboembolism, in which case the INR target is going to increase to 3.0. Mitral or tricuspid valves always require an INR goal of 3.0, so this is pretty easy to remember. In patients with onyx aortic valves, aspirin may or may not be added, and this depends on the individual thrombotic risk. Now let's discuss bioprosthetic valves. For bioprosthetic valves, the anticoagulation strategy is going to depend on whether the valve was placed surgically or via TAVR. After surgical AVR, we typically use warfarin with aspirin for 3 to 6 months. Then we transition to aspirin alone. For TAVR, dual antiplatelet therapy with aspirin and clopidogrel is used for the first 3 to 6 months, followed by aspirin alone. If the patient also has atrial fibrillation or under indication for anticoagulation, the regimen is going to evolve to include oral anticoagulation plus clopidogrel initially, then just anticoagulation. Now let's discuss antiphospholipid syndrome. In antiphospholipid syndrome, particularly in high-risk patients, warfarin is preferred over direct oral anticoagulants. This is based on data from TRAPS trial and others, which showed higher rates of recurrent thrombosis in patients treated with rivaroxaban. And so for now, warfarin remains the standard in this population. Now let's discuss ACS without PCI. So in patients with acute coronary syndrome who do not undergo PCI, very low dose rivaroxaban, 2.5 milligrams twice daily, can be added to aspirin and clopidogrel. This approach was shown to reduce cardiovascular mortality in the ATLAS ACS trial. However, one thing to note is that it also significantly increased the risk of major bleeding, so careful patient selection is key. Now let's go over CAD secondary prevention. In the COMPASS trial, combining very low dose rivaroxaban with aspirin significantly reduced the risk of major cardiovascular events compared to aspirin alone. Now, while this approach increases major bleeding, it did not increase fatal bleeding or intracranial hemorrhage. So it is going to be a strong option. For patients with stable atherosclerotic disease who are at high ischemic risk but low bleeding risk. Now let's discuss patient status post-PCI. So after PCI, the standard practice has been 12 months of dual antiplatelet therapy. However, newer data from the STOP-TAP2 trial supports a shorter course, just 1 to 3 months of DAPT, followed by clopidogrel monotherapy. And this strategy was found to be non-inferior in preventing events, and it may reduce bleeding as well. The DAPT score can help guide the optimal duration for individual patients. Now let's go over the summary table of the things that we discussed. So mechanical valves require warfarin, and bioprosthetic valves usually need anticoagulation or antiplatelet therapy short term. Warfarin is going to remain first line in antiphospholipid syndrome. In ACS and stable CAD, rivaroxaban plus aspirin improves outcomes in select patients. And after PCI, shorter DAPT durations may not be considered. So hopefully this video helps. Thank you for watching.